Okay, so we're going to finish up chapter 17. Now, with the initial settings that were included in this chapter, we used it in the lab yesterday to say what we should be starting with as far as is this a term baby or is this a preemie? And it really goes, of course, it goes case by case as always, but in general, we know that the smaller babies are are going to need to be ventilated, of course, a little bit more carefully than say maybe some of the larger babies. And because we are always concerned about barotrauma, this is the main reason why most of your facilities are going to expect that you use pressure control to ventilate them. Air leak, no cuff. So if you had a situation where there was a substantial amount of air leaking from around the ET tube, then trying to ventilate them in say like an AC mode or SIMV, it's not going to really work out. So that means that regardless of the air that's leaking from around the ET tube, if you use a pressure control mode, you set the I time, so it won't matter. It'll leak, but the the gas will still be delivered over that period of time that you have, say like zero point 0.8 seconds or whatever the case is. So then, of course, this was I just copied this from, as you see from this slide here, and placed it onto our handout from yesterday. And then I just added a few more details as far as like the older children, what you would probably want to start with. But again, it really comes down to, are you looking at a baby who's premature or are you looking at a term infant as far as where you're going to start things? Now, high frequency, it's got its own thing going on as far as where you're going to start. It still depends on the gestational age of the baby as far as where you're going to start, say like your hertz, for instance. And this here is just to show exactly every single parameter that you could either set or you could observe on this device. And of course, these are going to be the main things here, the mean airway pressure for sure. And your bias flow is going to ensure that you're maintaining your mean airway pressure, as well as also making sure that there's always some fresh air that's circulating in the system. And then the power is how you're setting your amplitude. So they're never going to order power. They're going to always order like amps, like, adjust your amps to achieve adequate wiggle or whatever the case may be. And then, of course, the frequency is in hertz, and the percent I time is pretty much 1 to 2 always with this oscillator. And then FiO2 is going to be separate. These machines, again, they don't have their own built-in FiO2 controller. You're going to have to, they have like a blender type of a system, but it's all like external. And then you still have to measure or analyze your FiO2 with an O2 analyzer. Okay, so we've said it before that your mean airway pressure is going to so we've said it before that your mean airway pressure is going to ensure that you maintain adequate oxygenation. And anytime that there is an issue with oxygenation with the oscillator, it's usually a matter of just increasing your mean paw to deal with that issue. Because we're always still trying to keep the FiO2, we're trying to keep the FiO2 as low as possible. If you have your optimal mean airway pressure set, you shouldn't have to use more than about 30% FiO2 anyway. And again, the lower the FiO2, the better. But we know that there's limits that we want to observe when it comes to the mean paw. We don't want too high of a mean paw because, especially with the tiny babies, that could be problematic for them. Now, for HMD, of course, this is again the old terminology. This is RDS. So with RDS, you're going to have more pressure because those lungs are so bad. I mean, the compliance is so bad that you're going to need more pressure. And you'll just have to accept that you're going to need to ventilate with much higher pressure. And hopefully as the baby gets better, you can start to titrate down on some of these parameters. And then for other problems, you don't necessarily need that high of a pressure. And anytime that we do make changes with our ventilators, whether it's an oscillator or if it's just a regular conventional ventilator, you don't really make huge changes. You're only going to make like one or two, especially when it comes to like pressure. And you just monitor and see how they see if they tolerated that change or not. Now, with this oscillator, you've got to keep your eye on it. So you just, you don't say like, just check it every couple of hours, or, sometimes even just checking it every hour may not be enough. You have to kind of see what's going on, because if the lungs start to improve, or if they start to get a little bit worse, then your measured values are going to change on the oscillator. You're going to have to probably go back and adjust your amplitude or your amps. And also you may have to adjust your mean airway pressure as well. Now, I just wrote that, this is a form that we've been using to calculate mean airway pressure, which just means that there's 4 different things that are going to cause your mean airway pressure to either increase or decrease. And as long as, we're increasing at least one of those, then we should be guaranteed that the mean airway pressure will go up. But again, with this machine, it's all about just setting the mean airway pressure directly. And that's a major advantage over other machines, because with regular ventilators, you can't set the mean airway pressure. You have to set everything else and then see what you end up with as far as mean paw. But with this machine, you directly are setting mean paw. And with the bias flow, even with the video that we saw yesterday or Tuesday, that particular hospital, they were saying that you should start your bias flow at 20 liters per minute. And of course, each facility's got their own thing, but that's kind of common as far as the oscillator goes. You're going to pretty much kind of start with about 20 liters per minute. And then if you got like a VLBW or like ELBW case, then you may want to go a little bit lower just because you got a smaller baby. And then when it comes to the amount of volume that is being delivered with this oscillator, it really will depend. It'll depend on the diameter of the ET tube. Are you using a 2.0 or you're using a 2.5 or whatever? That's going to make a difference. And then also the lung compliance. So with those two things, that's what's going to really dictate how much volume. Because again, you're not setting the volume at all with this machine. You're just setting your amplitude. But we could indirectly say that amplitude is kind of like tidal volume setting. Higher amplitude would mean should mean more volume, and vice versa. So let's say that they didn't label this, but let's just say that this is your pressure time situation. So these will be like your peak pressures at the very top here. And again, if you go back and you adjust your power, you turn your power up, and now your amplitude goes from 70 to 80, then you're going to have a higher peak pressure, and then you're going to subsequently have more volume. So just like with conventional ventilation, if you want to have more volume and blow off more CO2, you're going to need to have a higher amplitude. Now the frequency, here's where it's like bizarro world. I mean, everything is backwards when it comes to oscillators and frequency. Because we're doing hertz, we're generating extremely fast breath rates, like 8 hertz, 6 hertz, 10 hertz. Then, first of all, your guidelines will tell you where to start your hertz. If you've got a preemie, you're going to probably start your hertz at like 10. But if you got a turn baby, then you may start at 15. Now, anytime that you see that your CO2 is getting higher than what you want it to be, then instead of increasing your hertz, you're going to need to decrease your hertz. And the reason is that here is a picture that shows, like, again, your amplitude and what am I trying? How am I trying to make this easier to think about? So this is just a situation where you've got your hertz set at 8, which will be 480 cycles per minute, or 480 breaths per minute. Now the green and the blue is representing like volume. So volume underneath the curve is going to mean volume that is being delivered to the airways. Now, if you go back and you drop your hertz from 8 to 6, notice how you're kind of slowing things down a little bit, which means that this curve now is a little bit wider. And now that it's a little bit wider, you got more area underneath the curve here. So more area would mean more volume. And that's your strategy. Anytime that you are changing your hertz to deal with a CO2 problem, if you want to blow off more CO2, you've got to slow things down. You've got to decrease your hertz. And then that'll make the area underneath that curve a little bit bigger. The lower you go, the bigger, of course, the area that's going to be underneath the curve, which translates to more volume. And then when it comes to you have too little CO2, then you're going to need to increase your hertz. And now you're making the curve a little bit more narrower, which means less volume. Now, the ID ratio, again, is never going to probably deviate from 1 to 2, meaning that the machine will be set at an I time percent of 33, and that's it. I was trying to think, I can never remember, not even like in the sickest of sick cases, where they wanted us to change the I time percent. It was always, we're adjusting the hertz and the amps, and of course the mean airway pressure, but never the I time percent. It was always pretty much just 1 to 2. And strategy wise, it's all about keeping that FiO2 as low as possible. The more premature, the lower the FiO2 you need to be targeting, the lowest that you can get away with. And if you have to start at 100%, then you're going to quickly try to get that weaned down. And whatever your guidelines are saying, keep SAT greater than, so here it is saying, keep your SAT greater than 90%. Now, so we know that if you increase mean airway pressure, that would mean that oxygenation will go up. But what if you can't really go up any higher on your mean airway pressure, because you're already at like that top end of what's considered to be safe? Then you can consider inhaled nitric oxide could possibly be something that might help with the shunting. And also you could give PEEP, but PEEP is not something that's going to be part of the oscillator. This would be something you'd have to create yourself, and no one's going to really try to go through that kind of trouble, because your mean airway pressure is essentially your PEEP anyway. So that is thrown in there just to say that, let's say that you're using a machine that isn't an oscillator, but is still considered to be a high frequency generator. It might have an option for you to set PEEP. And without really getting to the brands and being brand specific, there's some high frequency machines or high frequency generators that don't really create the same type of breath as, say, like the oscillator does. It does the same thing, but the way that it does it is a little bit different. And that's all I'll say about that. Weaning is not overly complicated at all when it comes to babies and pediatric population. It's the same thing that we're looking for with any patient. Are they getting better, or have they gotten over their issue that got them intubated in the first place? So that's the first thing, because you're never going to consider weaning a baby if there's still evidence that there's a major problem with oxygenation and the lungs are still, there's a lot of atelectasis or whatever the case may be. And then the spontaneous breathing, they got to be able to breathe spontaneously, just like I said with any other patient. If there's still some periods of apnea that they're having, they're not going to be a good candidate for weaning. And the CO2 would have to be acceptable. So then when it comes to other things that we're looking for, we're going to be always trying to wean their settings as they do show signs of improvement. So here we're saying that as long as you have if their PIPs are less than 30 and their respiratory rate, their frequency is less than 20, and as you see, 20, 15, and 10, and PEEP is less than 8, and you've got the FiO2 below 50, preferably below 40%, and everything else checks out, then you would consider weaning. And in some cases, these would be minimal enough settings where you could even possibly consider extubating. Except for that PIP, though, you probably would want to get the PIP down to about 20 before you would consider extubation. Now, we know that when it comes to the amps or the delta P on the oscillator, we associate that with the tidal volume setting. And as they get better, you should be able to decrease their amps. Now, each day when the baby gets a chest x-ray, and if this is a baby who's on an oscillator, one of the things that they're going to be doing, and they like for you to do as well, is to check the film and check the picture and see how many ribs do you count. And the way that you count ribs, I mean, with this baby's picture here, I can kind of see the anterior ribs and then I can see the posterior ribs, but it's not that clear as far as the anterior ribs. But when we're counting ribs, it's mostly the posterior ribs anyway that we're looking at. And anywhere where there's black, which would represent air inside of the lung tissue, that would be counted as a rib. T9, or around, if you see about 9 ribs, that's usually sufficient. Sometimes the physician is going to specifically write, make sure that you can count X amount of ribs. Otherwise, you've got to adjust your amps because maybe you're over ventilating this baby or over distending the baby if you count more than 9 ribs. Or if you count way less than 9 ribs, then you may need to go up on your amplitude. And then that should take care of it. So I'm not even going to really try to distinguish between the anterior and posterior because I can kind of see it on the right side, but not really that clear on the left side. So here's 1, 2, 3, 4, 5, 6, 7, 8, 9. And then it's like a little bit here I can see. So that will still be considered good because I can count at least 9 ribs. That's rib number 10, 11, and then 12. And that's not the most accurate way of determining whether or not you have adequate lung inflation. It's still being practiced, but it's just not something that's that reliable because what if you miscount? Or what if you can't really see that clearly? So it's kind of subjective in a sense, but it's still something that's, again, being ordered and being done almost like on a regular basis with these babies on the oscillator. And troubleshooting, it's not too much involved with troubleshooting when it comes to a baby on a ventilator. It's always, start with the patient first. And like in this case, what if it's a baby on the oscillator and he's deteriorating? All the alarms are going off on the overhead monitor. Maybe the oscillator's alarming. Then what you do is you check for that wiggling. You see if the chest is still moving like it's supposed to be, if there's any wiggling. Now, if you don't really see any movement of the chest, then of course you're supposed to quickly disconnect and then manually ventilate with your ambu bag, and then you try to troubleshoot what's going on from there. But it still doesn't really deviate from any other patient troubleshooting situation on the ventilator. You got to start the patient first. Okay, now the questions that we have for chapter 17. Which one of these is going to help to keep the alveoli distended? No takers? No one wants to take a risk? Then what do you have to lose? Okay, thank you, Ben, for making the effort. So it's not the actual inspiratory valve that's going to make sure that the baby's lungs stay inflated. It's the bias flow. That's what you're going to be. It's like the little knob on the machine that looks like a flow meter. So you've got like the knob that you turn, and then you see the little ball that floats just like a regular flow meter does, and then that's how you're adjusting your mean paw or your mean airway pressure. Which type of high frequency does this? The keywords here being accelerates the gas. So yes, it's the jet. Those little tiny pulses of gas that it shoots down into the airway. That's pretty much how it's going to get it's how it's going to deliver the volume. But again, it's not inflating the lungs. It's not doing any of that. It's just shooting these little tiny pulses of gas, and CO2 will passively leave. All right, now, which one of these modes would work best here? So we want to do pressure support with volume guarantee. Think of how sick this 10-year-old is. ARDS. Yes. So we got to be thinking like a pressure control situation. And I remember, pressure control is not that comfortable, but APRV is pretty comfortable, and it works a whole lot better than pressure control. They're both pressure limited, because in pressure control you set the pressure. In APRV you're setting the pressure. Well, really two pressures, a high pressure and a low pressure. But either way, he could continue to breathe spontaneously no matter what, whether he's at his high pressure or if he's at his low pressure. So again, the key here was that this is a patient who's pretty sick if they've got ARDS. So any like mode like CPAP, he'd fail, because you know that if you've got ARDS, your lungs are not that great, and you're expected to be able to do all of your breathing yourself in CPAP, and you're supposed to be able to support your own ventilation. And then PSV plus VG, or pressure support ventilation with volume guarantee, that's, again, he's too sick. C and D would be more along the lines of someone who's almost ready to be maybe extubated. ARDS, you're nowhere probably near consideration for extubation. So always keep that in mind when you're trying to pick between different modes and they give you what's going on with the patient. Unless this is someone who's doing pretty good and looks like they may be on their way to possibly being extubated at some point, stay away from these modes that are going to expect you, the patient, to do everything yourself, like CPAP, and definitely PSV expects you to do everything yourself. B would have worked except for the fact that we really don't do inverse ratio with pressure control anymore, because we have a better means of doing it, which is APRV, and that's safer. PCRV is not that. It's very prone to barotrauma, is I guess what I should say. Now, what is PRVC doing here? Well, what do you think it's doing? You set a target tidal volume, it's going to try to keep a safe peak pressure to achieve that tidal volume. In order to do that, what will the machine have to be adjusting automatically? The eye time, does eye time affect your peak pressure as the peak flow? And remember, in any kind of pressure control mode, you cannot set the peak pressure. If you did, the machine could not do what it's supposed to do. It's supposed to be able to limit the pressure, and to do that, it needs to be able to adjust the flow rate. Sometimes it may need to deliver the breath a little bit faster, and other times it may not need to deliver the breath as fast. And that's usually like a breath by breath basis. So that's pretty much all it's doing. It's just, it's pretty much, I consider PRVC still to be pressure control with the added benefit of being able to get a pretty consistent tidal volume with each breath, regardless of what happens to the lungs, as far as the lungs get more non-compliant or if they end up having more resistance. True or false? Well, I think you could look at this and ask yourself, what does mean airway pressure do? And then you think about, well, what is a time constant? So this is a false statement, and reason being is because your mean airway pressure is all about increasing your FRC and improving oxygenation. Your time constant is just looking at how long does it really take to inflate the lung, or how long does it really take for the lung to deflate? And that's dependent on two things. It's dependent on your lung compliance and your resistance. So really, if you multiply your compliance and your resistance together, you get a pretty good idea of the time constant that's going to be, I mean, again, the time is going to be necessary to get the lung to inflate to about 60%. Most times you'll see them talk about time units or time constant units, like the first unit, the second unit, third unit, and they're breaking it down that way. But really, it's just all about how long is it taking to inflate that lung, at least to the point where it's about 60% inflated or deflated. And again, these two have nothing to do with each other, not like this. If that goes up, that doesn't mean that mean air pressure is going to go up with it. All right, so this is something that was mentioned in, I'm trying to remember, okay, the video that we saw the other day, based on that hospital's guidelines, was saying one thing, and I believe in the chapter, it is saying about 2 to 6. So in other words, whatever your mean airway pressure was like when you were on the regular ventilator, once you switch them over to the oscillator, it should be a little bit higher. You should be setting it a little bit higher, in other words. So about anywhere from about 2 to 6 higher than what the machine was measuring for mean airway pressure on the other machine. Now, which one of these is the true statement? 3 of these are definitely false, but which one looks to be true? All right, with the oscillator, the piston moves forward and it moves backwards. And it just keeps going back and forth, back and forth. And as it moves forward, it's pushing the gas into the lung. And then when it moves back, it's pulling it back out. So that's why the oscillator is considered to be active inspiration and active expiration, or active inhalation and active exhalation. So it's never going to be like a natural passive exhalation because of the piston. It's going to always be pushing and pulling, pushing and pulling, pushing and pulling. Okay. All right. So that's chapter 17. Now let's take a look at what's going on with the CPAP and BiPAP. So a lot of this stuff is things that we've already, well, there's your answer right there. Not even going to try to hide it. So sorry about your thoughts for today, but I guess we can go ahead and just get started on it here. So with this chapter, well, chapter 15 is all about CPAP. And then even when we get into chapter 16, which is non-invasive positive pressure ventilation, there'll be a little bit of the same information that was mentioned here that's brought up again. So we'll just look at, in general, what happens with CPAP. As soon as you place the baby on CPAP, what should happen as far as physiologically. And then we look at who's a good candidate and who's not a good candidate for CPAP. Then we look at the options that we have for setting it up. How many different types of systems do we have that we could generate CPAP with? And then management, so patient management. And then how do you wean a baby from CPAP? So then this was your thoughts, of course. I'll just go ahead and do this to say that as we look at what's going on here, everything looks to be okay. I mean, the heart rate, we know for neonates this is fine. Saturation is definitely fine. But the only thing that's really a problem right now is the temperature. So because of the temperature, the baby needs to be warmed up. And he needs to be under that warmer, and you need to get them under the warmer quickly. So that's pretty much, the situation. If he's big enough, he will be kept under the radiant warmer in the nursery. If he's tiny and he's below a certain weight category, especially if he's a BLBW, ELBW, he's going to need to be placed inside of an incubator because being in a radiant warmer is still probably not going to work out too well for a baby that's really small. All right, so we've seen this again and again that when you place a patient on CPAP, the first thing that happens is that their FRC is going to go up. So increase in FRC is the goal that we're shooting for, especially when you're dealing with like RDS. And if FRC starts to increase, then that would mean that you should start to see improvements in saturation, and also their lung compliance start to improve. ultimately their VQ ratio is going to be better if you can get the oxygenation to improve. And then you should see your overall work of breathing not be as high. No more retractions, hopefully. And then the last point here, what does CPAP really do? Of course, it is decreasing your shunt fraction. And your overall work of breathing is going to be lower. So all of this is going to happen because you're improving overall gas exchange and and then of course you're not going to have as much alveolar dead space anymore. So there's going to be adequate ventilation as well. But CPAP is all about supporting oxygenation. It's just that with babies, they get like a secondary benefit of having better ventilation as well. But never consider CPAP as a method of improving ventilation. Your baby still has to be able to maintain a normal CO2 or an acceptable CO2. And if they can't maintain a normal CO2 or acceptable CO2, they're going to fail CPAP. And you're going to have to now do something else. And that will usually end up being like, that'll mean like intubation. So all the different lung problems that we saw in chapter 22, many of them can be treated with CPAP. So as you see, like the neonatal pneumonia, especially TTN, if the oxyhood isn't really working for them with the TTN, then you'll just place them on nasal CPAP and let them get better that way. And even meconium aspiration syndrome doesn't automatically mean intubate and place them on the ventilator. You could do CPAP and see how it goes from there. And then the baby who needs to have surfactant, as we saw in the video, it's just so easy to quickly intubate them, deliver the surfactant, and then just place them right back on CPAP. So they were calling that the insure method that pretty much all hospitals will use. Now, the guidelines that we have from our AARC, they say that this is a prime situation when you should consider CPAP. Anytime that the baby's efforts to breathe, like their respiratory rate is more than 30% of what it should be or what it was before they started to take on this increased work of breathing. And then it's showing all the classic signs of increased work of breathing, the retractions, the flaring, grunting, etc. Then you should be setting up CPAP. And the last bullet point is, again, if they are also having issues with ventilation, CPAP's not going to work. But again, if they're ventilating okay, and then you get them on CPAP, the CPAP will kind of help to support their ventilation as almost like a little added benefit. But again, CPAP, oxygenation, not ventilation. And that's for all patients across the board. Now, contraindications. 60 may be acceptable CO2 for some babies, especially if you've got a baby who's developed BPD. But in general, if their CO2s are trending upward, then they're going to need to be intubated. Same goes with the pH. If the CO2 is going up, then that means that the pH is more than likely going down as well. Upper airway problems. And that would be something along the lines of like the choanal That's definitely an automatic. Don't consider that until they've had surgery to fix that problem. Diaphragmatic hernia, that's another, you should be thinking this baby needs to be intubated, not placed on nasal CPAP. CNS depressant means that Now you've just knocked out the baby's drive to breathe. And how do you think that they're going to be successful on CPAP if they're unable to breathe? And same goes for central apnea, or neonates that are born with, apnea prematurity. Very premature babies that are just not, with the underdeveloped nervous system, just not getting the message to the diaphragm to breathe. Hazards. This is positive pressure, and with positive pressure comes a lot of side effects that the patient will sometimes have to deal with, especially if they're already volume depleted. If you got someone who's already dehydrated, placing them on positive pressure is just going to make those side effects even more so. Pneumothorax secondary to auto-PEEP after you give surfactant. So this is why you got to pay close attention to what's happening with your baby and what's happening with the CPAP machine, because if you've just given surfactant, you never know exactly how long it's going to take before it really starts working. It may happen pretty quickly, or it may take a little bit more time. But once those lungs do start to get more compliant, your CPAP setting may end up causing overdistension or auto-PEEP or air trap, or what you want to call it, and that could lead to barotrauma, as you know. The nasal irritation. Those nasal prongs are soft, but even still, they create a lot of problems sometimes. They create a lot of skin breakdown, and you sometimes can get some pretty bad necrosis where they're going to need to have plastic surgery to fix it. We do our best to try to minimize that, and I'll talk about a strategy that a lot of times that will be used to kind of minimize that from maybe happening. And then with these prongs in the nares, they should fit pretty tightly, but not too tightly. And if they're not the right size prongs for the right size baby, there's going to be a lot of leaking. And if you leak a lot, you can't maintain your CPAP pressure. So you're always going to be at a lower CPAP than you're supposed to be. Now, the delivery system is just the machine itself. Like, what kind of machine are you going to use to generate this pressure and provide the humidity, provide the oxygen, et cetera. And then the interface is just that. What type of connection are you going to be using between the patient and the machine? Are you going to use a face mask, or are you going to use like a little nasal mask, prongs, which is kind of like the standard. The standard is usually the prongs. Or if they're still intubated, you could just use their ET tube, connect them to the ventilator, and switch it over to CPAP mode. There's some more terms here. VCPAP is just like ventilator CPAP, which means that the ventilator that you use to help the baby get over whatever their problem was, and then you extubated the baby, you would be expected to leave the ventilator on standby, just in case. So that means that if he or she starts to deteriorate after extubation, the ventilator is still there, and you can grab a mask and connect it to the ventilator circuit and then provide them some CPAP that way without having to really re-intubate and then switch them over to CPAP mode. So that's the whole VCPAP. But then companies have made their own little machines that work independently. You don't need to have a ventilator. You've got this little CPAP machine that you'll just roll to the side of the bed and connect your baby that way. Bubble CPAP, there's a video in this week's video section in Canvas where you could see how they set up the bubble CPAP system, and it's pretty straightforward once you kind of like get a feel of like the different parts and what you're expected to do with it. Very simple. hospitals have been saving money by making their own bubble CPAP systems instead of buying the ones from the manufacturer. Because all it really would take is some kind of container with water, and then take your tubing and the exhalation side, dip that in the water, and then provide some constant flow through the other side of the tubing, and you've got a bubble CPAP set up. And you can adjust your CPAP by just how deeply you are inserting this end of the tubing into the water. And again, with these commercial devices, they'll show you, there'll be markings on the side of the container with the water in it that'll tell you that you pull it up to this level, then you're going to be giving this much CPAP versus that much CPAP. Your constant gas flow needs to be somewhere around 6 to 10 liters per minute. Now, this 6 to 10 liters per minute is not only generating the pressure, the constant pressure inside of the airways, but it also needs to be enough so that when the baby starts to breathe in, it's still going to be enough flow to keep the pressures pretty constant. One of the easiest things to troubleshoot when it comes to a CPAP system, if you notice that the pressure is supposed to be at 5, but every time the baby breathes in, it drops down to like 1. And then when the baby exhales, it goes back to 5. That's a classic case where you've got to turn up the flow, because it's just not enough flow to, 1, keep the constant pressure of 5, and 2, it's not enough to meet the baby's demands, because the baby is needing a lot more flow. And you just crank up the flow, and that'll usually take care of that problem. So this is, again, how you could just create your own little bubble CPAP system if you didn't want to spend the money on the one the manufacturers will make for you. And that's all it really requires. Now, the infant flow CPAP. Now, this is definitely like a little standalone unit that will just be placed at the side of the bed and then connect everything. And then you don't have many controls to work with and not many things that you have to worry about. This one here is the one we used to use a lot, but ours was by a company that called it Aladdin. So we would just always refer to it as the Aladdin. And what this does is, here's the part that regulates how much flow. It's just like a flow meter. And over here, these are the LEDs that will light up. And as you can see, here's like green, yellow, red. And if you have your flow, it usually takes about, if you turn your flow to around 8 liters per minute, somewhere around 6 to 8 liters per minute, if the mask or the nasal prongs are tight, if there's not much of a leak going on, then that will give you a CPAP of about 5. And then up here, it shows your FiO2. And again, whatever this is pointing to may not be the same number here, because this has an internal sensor, an O2 sensor that is measuring the FiO2. So if this is turned to 40, this may say 36. And you go with this. This is what you're documenting, not this, but this. And then this over here, I just included this as another type of infant flow CPAP system. It's called the SiPAP, the SiPAP. And Sigh is just a shorthand way of saying sigh, like SIGH, take a big breath. And with the SiPAP, it's kind of like BiPAP, kind of. You have to set 2 pressures in SiPAP. And then, depending on how many sigh breaths you want the machine to generate, it'll send the baby up to about, like right here, it looks like they've got 6/4. Then what it'll do is uh, not 6/4, but they've got 6 and whatever their low pressure set. I can't really see from there. I can't really see from that graph there, but either way, it generates a little bit more, like about 1 or 2 higher on the side press, and it's supposed to be more comfortable for the baby, but some hospitals don't really buy into it. They just say, okay, well, we see what they say it does, and as far as the benefits, but a lot of times, they'll still get some of the same benefits from just CPAP. Your nasal, high flow nasal cannula, or like the Vapotherm, is probably the most common system that's out there. There's others, but everybody kind of knows Vapotherm because they were one of the first ones on the market, and they've been around for a while. So with the high flow nasal cannula, you can generate positive pressure. And instead of having to have like a separate CPAP machine, you could just use your high flow cannula to generate CPAP. And this is an example of how you make your own high flow nasal cannula. All you really need is a heater, humidifier, or water chamber, your blender, and your tubing. And then, of course, you got to add in some kind of safety, like a pop-off valve. So that way, if any back pressure builds up, the lungs will be protected. And that's pretty much all you would need. But then if you wanted to go with commercial version, then you're going to need to, of course, get something like a Vapotherm. And this little flashing icon right here, it's just telling you that, hey, there's a blockage in the circuit somewhere, because water is being delivered through the circuit, and it's heated water. And so if something is now blocking that passageway, then it's going to alarm and let you know you need to check. And a lot of times it's just a kink that you'd have to undo. All right, so now we know that when it comes to invasive versus non-invasive, we're always going to probably try to go with the non-invasive route first. And let's say that we've got a little baby who needs to have CPAP, then you're going to probably have options. You may have bubble CPAP units in your facility, and you may have like infant flow systems that you could use. And then it may come down to your preference. You may have to decide, which one of these systems do I want to use? So then you get everything together. You have to have the right size cap, because if you use the wrong size cap for the baby, you're not going to get the proper fitting. Everything is not going to fit correctly. And then you got to get the right size nasal prongs, and then of course circuit. If nursing hasn't already inserted an OG tube or an NG tube, they're going to have to. You're going to have to get them to do that, because with CPAP, there's going to be some pressure going into the stomach. There's going to be gas going into the stomach, and you're going to need to be able to vent off that gas and decompress the stomach. And then you just, of course, whatever your orders are, you enter those into the machine, and then you make adjustments as you need to, and you monitor. So it's essentially like it's another vent check, just like you would for a regular ventilator. It's just that you're going to be documenting different things and not as many things. So here we go with the baby has to be able to breathe again. So I can't stress that enough. If they're having periods of apnea, don't even think about setting up CPAP. Or if the physician isn't aware that baby's having a lot of periods of apnea or lots of A's and B's, then again, just tell the physician that this is not going to work out. Baby's still having way too much apnea. And then as far as our objectives, it is all about usually like reversing atelectasis. So if they've got a lot of issues going on, like with RDS, then this CPAP will definitely take care of that. And we're always trying to make sure that we have optimal settings in place. And that's why, again, when you're monitoring constantly, or regularly, I should say, not necessarily constantly, but you're going to be regularly monitoring everything to make sure that you are using optimal settings. And hopefully the baby will get better on the CPAP and you won't have to even worry about intubating and place them on ventilator. So where do we start? If they don't tell you where to start, and they usually will have their preference, they're writing the orders where they want you to start the CPAP. Well, let's say they don't do that, they just leave it up to you. And then you may want to just kind of start like maybe anywhere from 4 to 6 with your CPAP. And if you're using one of those infant flow systems, then as we were seeing, you're going to have to turn up the flow as necessary to generate the amount of pressure that you need. Now, what if your baby is not doing that well on CPAP? You may need to go up on the CPAP, which means you go up on the flow. And let's say the baby's still not doing that great. And you go up on the CPAP again. If you find yourself having to go up to say like 10 or more of CPAP, that is the baby telling you that they're not going to get any better. They're getting worse. And that just means that you're going to have to now consider intubating. Because it shouldn't take that much, no matter what type of problem that they have. So this is the whole thing about optimal CPAP may have been exceeded. If you find yourself having to go way up and then things are kind of like going in the wrong direction, CO2 is starting to go up, PO2 is going down, no matter how much you go up on the CPAP, that's a pretty clear sign. And then the smaller the baby, the more likely they're not going to do that well with CPAP. So like your ELBW babies are going to probably you're just going to have to cut to the chase and probably intubate them and place them on the ventilator. So what do we monitor? I mean, pretty standard stuff. You got to monitor your vitals. You got to check breath sounds and document heart rate and saturations, et cetera. And you may have to also comment on some other things. You may have to comment on, especially the condition of the nares. This is a legal thing here. You definitely need to be documenting with each time that you do an assessment with a baby on CPAP. You've got to take a look at what's going on with their nose and make sure that there's no red, over red, or white, which they call blanching. That would mean no perfusion, and et cetera. Then your alarms, just like with the regular ventilator, you want to set alarms if the machine allows you to set alarms, and then check to make sure that they're working and everything is set correctly. And it also goes for your heater. Bubble CPAP, that's the whole name of the game. It needs to be bubbling. And so if it's not bubbling, then that could mean that you got maybe possibly a leak somewhere and you got to do some troubleshooting. And then the large fluctuations and pressure, this is what I was referring to earlier when I said, what if you've got your CPAP set at 5, and every time the baby breathes in, the CPAP drops from 5 to like 1. Doesn't go to 0 and stay there like it would when there's a leak, but it bounces back and forth too much. If all you see a bunch of bouncing around like that, then it means that you got to turn up the flow because of the baby's demands are higher. All right, proper care, or what does that really mean? That just means, again, you're doing your due diligence to make sure that everything is working and there's no skin problems and the patient is improving or maybe not improving, et cetera. So really it comes down to how familiar are you with your equipment? If you're working in a nursery, they're going to expect you to be proficient with all of the equipment. So every year or biannually or whatever the case may be, they'll have you do checkoffs just to make sure that you still know how to set up this equipment and you understand how it works and et cetera. So just when you thought that lab checkoffs were done, now that you graduated, you're still going to have checkoffs just to make sure that there's a certain level of competency with the equipment. And that goes for beyond the nursery, even with the adults. If they're using, of course, like ventilators or whatever, especially if you're using certain types of ventilators with certain modes, they're going to expect you to be able to pass these little competency checkoffs. And then if you don't pass, then it's not like they're going to automatically fire you. They're going to give you a chance to remediate and get back up to speed on everything. Troubleshooting is all we do, it seems, because there's always something that's alarming, it seems. You know, something's alarming, something's not quite working right. And with CPAP, it's leaking, and you got to try to fix the leak. And then you kind of just have to go from there. So with the prongs, those nasal prongs, you got to have the right size, and the package will tell you what size that they are, and then there'll be usually like a reference to kind of say that if the baby is this many kilograms or this many weeks gestational age, they may include that or they may not. And then you may have to kind of like just take the prongs and just kind of eyeball it and see if it's going to be the right size for that particular baby. A lot of times they try to make it easy for you and just, you know, based off of like some general things like the weight and that sort of thing. But we never want to see blanching ever, because again, blanching is white, which would mean no blood flow. These prongs are way too tight. And you know, it'll just be a matter of time before there's some skin breakdown. And then because of their little tiny airways, and even if you're using you're using heated humidification system, they still get a lot of mucus plugging sometimes. And you got to just make sure that you go in on a regular basis. And a lot of times all it takes is using the bulb syringe and clear out their nares. And even if you got to use a suction catheter, you'll be amazed at how much stuff that you get back from these little babies sometimes. Baby's no bigger than your hand, but you're pulling out mucus plugs the size of I don't know, I can't think of an analogy right now, but I hope you get the point that a lot of times they do produce a lot of mucus, even though they're small. So you just want to be careful and always checking and making sure the airway is patent. Now, weaning, just like with any case, they've got to look like they're getting better before you even consider weaning. And all signs have to point to that. And always get the FiO2 first. Try to get them as low as possible. And then you start working on your pressure, your CPAP. So if you can get down to like, as they say, like around 3 to 5 CPAP and everything is still looking fine, then that should be enough to convince you that the baby should be okay. Just place them on. They probably just need to be, they may be okay on just room air, or they may need to be placed on a nasal cannula. Okay, and then chapter 16, it's all about non-invasive positive pressure ventilation. You know, we've pretty much said like this is like BiPAP, but BiPAP is actually a trademark name for one company. So that's why it's always just kind of mentioned as NPPV. Okay, now, what are our objectives when it comes to non-invasive positive pressure ventilation? It's all about, you've got someone who's in distress, how do you get them out of distress? And that would probably be BiPAP. I'm going to say BiPAP. That'll probably be NPPV that's going to help them. And then because you got two different levels of pressure, like with NPPV, you're going to get the ventilation and you're going to get the oxygenation taken care of at the same time. So with the oxygenation, it's all about the increase in FRC. And that's the first thing that happens when you start increasing the baseline pressure. It also stabilizes your upper airway. So if you got someone, say, like a sleep apnea, obstructive sleep apnea, then that constant pressure is going to ensure that the airway doesn't collapse. Now, NPPV and CPAP are going to be beneficial for patients with restrictive diseases. But what if you got someone who has, say, like issues like some kind of chronic lung issue, and at nighttime they definitely are going to need some help with ventilation. And we all breathe more shallow at nighttime when we're sleeping. But for someone with some kind of lung disorder, chronic lung disease, it's even more so. So then that's when NPPV would win. So you don't want to think CPAP, because again, CPAP is not ventilating. That's why there's no V in CPAP, but there is a V in NPPV. So here we go again with the the high flow nasal cannula. And then we know we could use high flow nasal cannula as CPAP. It could generate the constant pressure that's necessary. But in some cases, you could use just a high flow cannula as well. And it'll generate enough pressure that would be like the equivalent of like a CPAP. And it's keeping the airway open. So then that should help to support ventilation as well. Obstructive sleep apnea and morbid obesity. So this is one of those situations where, for sure, don't consider CPAP when you've got someone who's got not just sleep apnea, but maybe they've also got like they've got some other issue as well. They call like that's late in the day and I'm like losing it. Maybe that's something, I'm just going to say there's a comorbidity that they've got along with their OSA, and CPAP would not be enough by itself. Because generally, if all they have is just obstructive sleep apnea, then all it would take is just CPAP to keep the airway open. But let's say you've got OSA and you've got some kind of restrictive lung disease on top of that, then you're going to need to think NPPV. And especially if you've got central sleep apnea, NPPV is essentially a ventilator. It's just a non-invasive way, and you set a rate or a frequency. So if they stop breathing because of some kind of central nervous system issue, then at least they're going to be okay as far as still being ventilated with NPPV. Now, Pickwickian syndrome, if you haven't already talked about that or seen it before, this is just another way of saying morbid obesity or hypoventilation obesity syndrome, or what do they call it? And I'm just going to say this is pretty much morbid obesity based on whatever your BMI is. So bilevel targeted ventilator. So we're still not saying BiPAP, but we'll call it BiPAP. But bilevel is just saying just that. You've got two pressures that you're going to have to set, and subtracting the lower pressure from the upper pressure is the equivalent of your pressure support. Now with these machines, they're usually smart enough to make adjustments for tiny leaks. Like if there's a leak that's happening and it's not a substantial amount of leaking, it'll automatically adjust for that. But if there's a huge leak, then it will be a problem for the patient, because even when they're trying to trigger a breath, it may not be able to detect that. And then there's going to be some dyssynchrony going on. So what are your settings? Of course, you got to set your IPAP. You have to set your EPAP. And then you got to have that backup rate. So just in case they stop breathing, or they just stop breathing, or they're given too much sedation or whatever, then they still have this backup rate. Ordinarily, this mode is expecting the patient to do all the breathing themselves or herself. It's more like spontaneous, but there's the time portion of it as well, which is this backup rate. And then the mode that you set, of course, if you set it in CPAP mode, there is going to be no IPAP or EPAP. It's just going to be just the CPAP, the one pressure. Then spontaneous is just purely just spontaneous. And then timed. Now, are you going to see all of these options with all of your machines? No, because they've taken away some of these options. So what you're more likely going to see is you're going to see definitely the option of setting CPAP. And then you're going to see ST for sure, which is just a spontaneous. The backup rate to apnea ventilation, no, it's not necessarily a dedicated apnea backup. It's just that similar to your AC mode, in AC mode, if you stop assisting, then you just go to control mode. So this is kind of the same thing. ST would be you're breathing, and this is all spontaneous. And then as soon as you stop breathing, it just goes into a time mode and gives a breath every however many seconds based on your backup rate that you set. So it'll never alarm if that's what I'm interpreting the question to be. It's just it'll automatically switch over. So when you're setting it up in like a time mode, then for sure, each breath would be time triggered. The machine will know how many breaths per minute that it needs to deliver. And then when you set it into ST mode, which is the most common way of running this machine is an ST, it will know that if the patient needs to take a breath, the patient has to trigger. So it's like flow triggering that you would have in any ventilator. So there's no option really for pressure trigger usually. It's mostly just flow triggering. Now, here's the thing when it comes to ST mode, because it kind of behaves like AC mode. Let's say that your patient, again, just for whatever reason stops breathing or falls asleep. Now the machine will just know that I need to go into time mode and give a breath every, let's see, I was using 15 earlier. Say your backup rate is 15, then it knows that it needs to give a breath, a time triggered breath, every 4 seconds until you wake up and start triggering again, which then it'll switch over to like spontaneous. And then the last point here, this is the most common mode that you're going to select, even with adults. It's much better to have them in ST mode than to just have them in like a purely time mode. Because if you put them in a time mode, then you're taking away the whole benefit of them being able to breathe spontaneously and do some work for themselves. Now, IPAP has to be greater than EPAP, because if you set them to be the same number, then you're just generating CPAP. And you got to remember, this machine has a dedicated CPAP mode where you can just switch over and then dialing your CPAP. So it wouldn't make any sense to select ST mode, and then the machine is asking for an IPAP and an EPAP, and you set both of them B8. So again, the machine won't complain, but you just now are not really delivering two different pressures like you are expected to. So 8 to 12 is usually good enough for most patients, as we have seen, at least for like a starting point. Then you have to kind of titrate from there. The only way that you really will know what the optimal settings are as far as IPAP and EPAP for any patient, whether it's an adult or a pediatric, the only way that you truly would know is if you do a sleep study. And during the sleep study or polysomnography, they used a BiPAP and they were titrating the settings based on your apneas and hypopneas events that you were having. And then once they titrated it to the point where you had very little apnea and hypopnea events, then they'll say this has to be your optimal settings here. And then that's what will be prescribed. And the physician will write the orders for use BiPAP at home with 12/7 or 12/6 or whatever the case is, based on what ended up happening in that sleep study. But if they didn't have a sleep study, they won't know, and you're not going to know. So you're just going to have to come up with like a safe starting place and then kind of go from there. EPAP is pretty much like PEEP, as we've seen, which means that if you increase EPAP, then that should help to improve oxygenation. And also at the same time, it's going to help to keep the airway patent and keep it from collapsing, like in the case of OSA. Now, what are your options? So here again, we could do little tiny silicone masks that fit over the entire nose, or we could do like a nasal oral mask for like the bigger pediatric patients. Or we could do like the little nasal prongs. They call them plugs here. It's the same thing. Nasal plugs, nasal prongs, or there could be nasal pillows. So really, again, depending on how large of a pediatric patient you're working with, you may have the option of, like in the case of like an 8-year-old, you'll use like a nasal oral mask, maybe. Or you may still use a nasal mask. But then when it comes to little tiny ones like this one, you're going to be going between either a nasal mask and the nasal prongs or nasal plugs, as they're calling it here. And what we used to do is we used to alternate. Each time we went to assess the baby, we had to switch out like so many hours on the nasal mask and then so many hours with the nasal prongs. And the only reason was because those prongs can over time cause a lot of skin breakdown. And the masks will kind of help to avoid that, but the masks are not very, what's the word I want to use here? They leak a lot. And I used to always envy the therapists who could set up their babies and even with a mask, have very, very little leaking. And I struggle with this. I'm not going to lie. Even though I would think I have the right size cap and I would have the right size mask and I Velcroed everything down, tied everything down, and it's still leaking a lot. So then I call over another therapist. Hey, Carolyn, can you come help me out? And then Carolyn would be like, okay. And then she could do something as simple as adjust the cap a little bit better and redo the Velcro a little bit differently. And then leak is gone, or leak is pretty much non-existent. Or sometimes it would just be flat out, I overestimated the size of the cap. And like, no, you got to get a smaller cap than this. a cap that looked like it won't fit on the baby's head. But then, they would put it on and then it ends up, being a tight fit, but everything works perfectly at that point. So that's definitely a skill, because in the beginning, again, I struggled. And even after I got the hang of it, I still wasn't that great compared to like some of the other therapists who could get the exact fit and everything to work the way it's supposed to and have very little leaking going on. So needless to say, I was doing a lot of adjusting with my babies all the time until I maybe called somebody to help. All right. And monitoring the patient and of course the machine. So we know that it really will depend on what's going on with your patient as far as like, is this even going to work? Or, maybe this is going to help a lot. And as far as your optimal settings, if the physician isn't giving you the settings, then it means that you're having to do the titrating, or you're maybe having to make the recommendations based on what you're observing. And the last point here, sometimes the babies or the children are going to be discharged home with this equipment, which means that at the house, you're not expecting mom and the other rest of the family or whoever the caregiver is, you're not expecting them to be proficient with this equipment and know how to troubleshoot. Now, if you're the home care therapist, you are going to help them do some basic troubleshooting. The equipment is not going to be that complicated. And that means that you're going to just have the family or whoever it is that's responsible for monitoring the patient at home is to just to make sure that they're keeping an eye on things and everything looks to be working the way it's supposed to, and there's nothing really alarming all the time. And that training really, or that education, I should say, really begins with the bedside therapist. So if you were taking care of this patient and the family had been visiting, you would have already started trying to get them a little bit more comfortable and familiar with like what's going on with that system. So that way, when the time does come and the baby or the child is discharged with the equipment, then the parent or the caregiver is going to probably feel a little bit more comfortable with the whole system. Complications, of course, we're always concerned about aspiration. You've got a mask on your face. It's providing this positive pressure. And depending on like if you've got just a nasal mask or an oral nasal mask, if you've got the oral nasal, then you could easily vomit and then it gets pushed right down into your airway. And that's going to be problematic. The masks are designed so that your patient should be able to snatch it off when they need to in an emergency. But then what if you got someone who's pretty sick and can't even do that even if they wanted to? So that's a big concern, the aspiration and the overall compliance, meaning like if you got a child who just doesn't want that mask on, they're going to be very agitated and they're going to probably snatch it off all the time anyway. So then that would be kind of like a contraindication. If you know you got a child who's going to fight a lot. Now, granted, you could probably use some mechanical restraints, but that gets to be complicated as far as you just can't order those kind of restraints just because you want to, or just because the patient is going to fight if you place them on like place a mask on their face or something like that. And then for a child who has to grow up with one of these devices, meaning that they had to start using it right after birth and up to the point where they got to be a certain age, it could change their overall structures, their actual facial structures. So that's a concern definitely for a lot of parents, is that, that's just one of those unfortunate things. And it may be to the point where they may have to get surgery if it's too much of a shift. Minor complications. Now, skin irritation, it could be a minor problem, but what if it's major skin irritation? Then that's when we really got to be concerned that we got to come up with some kind of solution, because if you've got that kind of skin irritation going on, it's just a matter of time before you possibly get a lot of breakdown, and then you've got a potential source for sepsis. And then under the others category here, the drying out of the airway. We use a heater, a heated humidification system to try to overcome this problem. But even with the heaters and humidification, that can sometimes still not be enough. And they may complain of being just too dry. The nosebleeds, that's usually related to not enough humidity. And then the eye irritation, those masks, they leak. And if they leak, a lot of times they're leaking right there where the top of the nose, right at the bridge of the nose, and then that air is just going straight into the eye. And that could cause a lot of eye irritation. Now, you're thinking about patients who can't tell you what's going on, who can't complain that this thing is just blowing right in their eye, then you're going to have to kind of figure that out. So what I used to do, and I think a lot of other therapists probably did the same thing, is anytime you place one of these masks on and you try to get it positioned and get everything secured, just kind of take your hands and kind of feel around the mask to see if there is leaking, because you expect a little bit of leaking, but if you feel a lot of leaking, and if it's right there around the eye region, you're going to have to do something differently and try to readjust so that way they don't end up with eye problems. And then cardiovascular instability, this is positive pressure, ventilation. First of all, you got to be in a monitored area. Don't set up a BiPAP for a patient who's on a general care floor who's not being monitored by telemetry. So there's no one that's keeping track of like their rhythm and heart rate and that sort of thing. So you've got to definitely be able to monitor continuously when you're using one of these devices. And if they're already unstable, then this is not going to help, unfortunately. In which case you would just have to consider just going straight into intubation. Now the questions, what would be the most common for CPAP? Those prongs, that's like almost like the gold standard. But just know that those prongs do tend to cause a little bit of problem with the skin over time. Which one of these is not a contraindication? Right, that is an indication. If they've got pneumonia, then they've got oxygenation problems. And as long as they're able to still breathe and ventilate, CPAP should work just fine for helping to improve their oxygenation. But these other problems, the choanotresia, the fistula, the congenital diaphragmatic hernia, stay away. And which one of these kind of systems would not require a lot of work for the baby? It's the infant flow CPAP system. So that would be like the picture that we had was like the CPAP, and then we had like the other one, I forget what model that one was, where you just dial in your flow and that sort of thing. So with these systems, they're the ones that are supposed to, because you can, with the more sophisticated ones, have more features that you can set, and that will usually make it a little bit easier for the baby. Well, we're looking for an absolute contraindication. So under no circumstances would you ever want to set up BiPAP if yeah, the hemodynamics. Again, this is positive pressure. If they already have poor blood pressure to begin with and poor cardiac output to begin with, you can imagine what's going to happen if you're now applying even more pressure inside of the thorax. True or false? Is this true? It's not true. Remember, it's the leaking. If there's too much of a leak, the machine is not going to be able to detect when the patient is trying to trigger a breath. And that could lead to some major dyssynchrony. If it's a small leak, the machine can adjust for that, and it'll still be able to determine when you, the patient, are trying to trigger. But big leaks is going to be a problem. And which one of these is going to keep the airway stable? All right, so yeah, that's their EPAP. And that's those two chapters. Again, a lot of it was kind of the stuff that we were talking about when we first started talking about CPAP and BiPAP. And then this was, again, the same, but just now talking about children and smaller patients.